And now I'd like to introduce our speaker for this evening. Dr. Greenside is a reproductive endocrinologist and infertility specialist with the Valley Hospital Fertility Center. She's been with Valley for over 10 years. She completed her residency training at New York University Medical Center in obstetrics and gynecology, and then completed a fellowship in reproductive endocrinology and infertility at Montefiore Medical Center. Dr. Greenseid is board certified by the American Board of Obstetrics and Gynecology and the Subspecialty Board of Reproductive Endocrinology. Welcome, Dr. Greenseid.
Thank you so much for having me. So I am here to discuss Pathway to Parenthood. Our goal at the Fertility Center is to provide access to fertility treatment for everyone that is looking to create a family. We know that family planning, as well as infertility, can be challenging and stressful. But there have been many advances in reproductive technology, and there are now more ways than ever to grow families. So let us develop a personalized plan for parenthood and help you achieve your dreams of family. So getting started, we need 3 things to make a baby. We need eggs, sperm, and a uterus. So I always start our conversation about which eggs, sperm, and uterus are we planning to use. We can use an egg from a patient or from their partner if they have eggs or if they want this option. We can also use donor eggs. We can use sperm from a patient or their partner, or we can use donor sperm. And we can have a patient or their partner carry the pregnancy in their uterus if they want to, and they have a uterus, or we can use a gestational carrier. Just to clarify, what is a gestational carrier? A gestational carrier is someone who carries and gives birth to a baby for another person or couple. And that other person or couple that they carry the pregnancy for, who is wants to have that child and raise that child, they are termed the intended parent or parents. So I thought it's important to start with a little background on conception in general, so we can better understand all of the options that we have available for treatment. So at the beginning of each menstrual cycle, the brain releases a hormone called follicle stimulating hormone, or FSH, which travels to the ovaries and stimulates follicles, which are specialized cysts that contain eggs, to grow. Each month, typically only one follicle or egg becomes a dominant follicle. There's a second hormone released from the brain called luteinizing hormone, or LH. You may have heard of the LH surge. And this hormone gets released from the brain and it triggers the final maturation of the eggs and ovulation of the eggs. The egg then moves down the fallopian tube where it meets the sperm. So sperm that is ejaculated into the vagina or sperm that is placed into the cervix or the uterus then travels through the uterus into the fallopian tube to meet the egg and results in fertilization. Once the egg is fertilized, again within the fallopian tube, it starts dividing and traveling down towards the uterus where it eventually implants and develops into a fetus. I like this diagram to point out what's going on in the ovary, which is on the top here, and what's going on in the uterus, which is on the bottom of here. Because sometimes we want to separate and use the ovary from one patient to obtain their eggs and the uterus of another patient to carry the pregnancy. So it's really important to understand what's going on in the ovary as well as in the uterus. In the beginning 14 days on this chart, everybody's cycle may vary a little bit. We see that the ovary is growing an egg and that egg makes estrogen. And this all happens due to the brain's hormones. The estrogen causes the lining of the uterus on the bottom here to grow and get ready for a potential baby. At ovulation, due again to that LH surge, the egg gets released and then travels into the fallopian tube where it could potentially be fertilized. The area where it got released from becomes a specialized cyst called the corpus luteum, whose job it is to produce progesterone and stabilize the lining of the uterus for a potential pregnancy. If a pregnancy occurs, the progesterone continues to be secreted and the lining of the uterus remains stable. If pregnancy does not occur, the progesterone stops, progesterone production from the corpus luteum stops, and a woman gets, or a patient gets their period. So let's talk about the initial evaluation. Coming in for a consultation to discuss options is often the best place to start. No matter what your sexual orientation is or your gender identity, you're going to need an egg, sperm, and a uterus to start your family. But there are also options to preserve fertility if you are not ready to start a family and you're not sure what your future plans may be. The first step in your journey may feel stressful, but we're here to make our patients feel comfortable. The initial meeting can just be a discussion, a background information on you and what your thoughts are and your dreams of parenthood, and it can also take place in the office or virtually. We'll investigate egg source, ovarian reserve, which is an assessment of the quantity of the eggs from the egg source, as well as ovulation, evaluation of the uterus, fallopian tubes, and sperm source, as well as sperm quality with a semen analysis. We also offer genetic screening for preconception. Let's get into some specific examples because I think this is the best way to delve into this subject. So I work with many lesbian or same-sex female couples, and our initial discussion always involves decisions on whose eggs, whose sperm, and whose uterus. Donor sperm is often used, and we discuss the option of using non-identified donor sperm versus a known donor, which could be a family member or a friend. We also discuss donor selection and consideration for preconception genetic screening to make sure the donor sperm is a good match with one of the partners or both of the partners, depending on what their ultimate plan is. There are some times when one partner wants to use their egg to create the pregnancy and their uterus to carry the pregnancy. And we discuss donor sperm insemination or intrauterine insemination. And sometimes both parties want to be involved, and we use the egg from one partner and the uterus of the other partner. And this is called reciprocal IVF or reciprocal in vitro fertilization. So if one partner wants to use their eggs and uterus, we monitor to see when they're ovulating so that we can perform the donor sperm insemination at the appropriate time. This is the actual process of the insemination. It's done in the office. It does not require any anesthesia. There is no downtime, and it takes about 5 minutes. A speculum is placed in the vagina, and a thin catheter is placed through the cervix into the uterus, and the sperm is deposited. And again, as I mentioned previously, sometimes both partners want to be involved in the process, and we pursue reciprocal IVF. In this process, on the left-hand side of the screen, one woman supplies her eggs, and she undergoes the IVF process and has her eggs retrieved. They are then fertilized with donor sperm, and the resulting embryos are then implanted into her partner to carry the pregnancy. I wanted to delve into this a little bit further just because I think that sometimes all of the lingo and language that I'm saying may not be clear. So what IVF entails is it begins with medications taken to stimulate the maturation of multiple eggs on the ovaries. And this is done by taking hormone shots and some frequent office visits so that we can monitor the growth of the eggs. At this time, an egg retrieval is performed. This is an outpatient procedure where mature eggs are collected from the ovaries and brought into the laboratory. These eggs are then fertilized with donor sperm by either mixing or injecting the sperm into the egg, depending on the sperm quality. And afterwards, fertilization occurs and an embryo is created. In the laboratory, we culture the embryo to the appropriate stage. And here is where we have the option to transfer the embryo into the uterus of the partner. We also have the option of taking the embryo, and before putting it in the uterus, we can biopsy it and check the genetics of the embryo to confirm that it does not have any chromosome abnormalities. This process is called pre-implantation genetic testing. Let's move on to same-sex male and single male patients. Again, we start with a discussion about eggs, sperm, and uterus. Donor eggs can be obtained from an egg bank, or an egg donor can be identified and undergo the IVF process, so fresh eggs are obtained. We then discuss which partner is planning to provide the sperm, and sometimes both male partners wish to pursue pregnancy and use their sperm. And finally, we discuss using a gestational carrier. I mentioned this earlier. A gestational carrier is a woman who carries and gives birth to a baby for another person or couple, again, the intended parent. When using a gestational carrier, the baby that she carries was not created from her egg. It is either from the intended parent's egg or an egg donor. This is different from the term traditional surrogacy. In traditional surrogacy, a woman who carries the pregnancy, that pregnancy was created with that woman's egg. And this is no longer used in the United States due to the legal implications that can arise. Laws vary from state to state, so it's really important that gestational carriers and intended parents have independent legal representation by lawyers who are experienced in the state where the parties live and intend to deliver. We assist in all aspects of this process. So this is nothing that should make you nervous or concerned. How am I going to find this? How am I going to pursue this? We help in all steps of this process. In addition, I think it's important to note that just as recent as 2018, the New Jersey Gestational Carrier Act was passed. So what this does is it provides legal protection for both intended parents as well as gestational carriers. So this chart here talks about the transgender options for genetic offspring. And each situation is so unique that I really think we should delve into all of the potential situations. So let's start on the left here with transgender men. This is what we think about. Does this transgender male have a partner? And does this partner have sperm? Does this transgender male want to carry the pregnancy? If they do, they can have intercourse or undergo intrauterine insemination. If their partner has sperm, but they don't want to carry the pregnancy, we can actually do IVF, and we can use eggs from the transgender male, sperm from their partner, and we can have a gestational carrier carry that pregnancy. Now let's talk about a transgender male who has a partner that does not have sperm. Again, if they want to carry the pregnancy, we can get them pregnant with donor sperm insemination. And if they don't want to carry the pregnancy, we can undergo IVF and retrieve their eggs fertilize them with the donor sperm, and have a gestational carrier carry the pregnancy. And then finally, some transgender males are not sure how they want to proceed, but they don't want to lose out on the opportunity to have their own biologic child. So they may come in and choose to freeze their eggs or cryopreserve their oocytes. So that way they have the opportunity to use them in the future should they want to. And now let's talk about transgender women. So let's talk about if the transgender woman has, if their partner has ovaries and a uterus, and does their partner, if they do have ovaries and a uterus, want to carry a pregnancy? If they want to carry a pregnancy, then intercourse or insemination are both options. If the partner does not want to carry a pregnancy or is unable to, then again, IVF and the use of a gestational carrier is an option. If we have a transgender woman whose partner does not have ovaries or a uterus, then we talk about egg donation and a gestational carrier. In addition, transgender women can pursue fertility preservation. So I think one comment here that's really important is that in general, the age of the egg really has the biggest impact on pregnancy success. And I think this is important because we don't want to rush anybody. However, we do want to make sure that patients have the ability to achieve their dreams of family if and when they're ready. So I brought up before the option of egg freezing. This is our best way to date to actually stop the clock. It involves cooling cells to sub-zero temperatures to stop biologic activity and preserve those eggs for future use. There are a variety of indications to pursue this process, and it's definitely something that we should think about, especially when patients are not yet ready to make that decision and they're not yet ready for a family. So egg donation, I brought up multiple times during the talk. This can be used in a variety of different situations where eggs are needed. We can achieve ovum donation, or egg donations can be obtained from a fresh donor who undergoes an IVF process, or we can obtain from egg banks, which are basically egg donors who have previously gone through the process and the eggs have been retrieved and they're in the banks waiting to be taken. And this is a great option because from a time perspective, the eggs are there. The donors have been screened, the donors have gone through the whole process of IVF, and their eggs are available to be used. So family planning, as I said in the beginning, can be really challenging and stressful. There's lots of barriers that exist, and we're aware of this. Financial limitations, including discriminatory insurance coverage, fears for patients due to prior negative experiences with the medical community, and misconceptions, like the assumption that having children was not a priority or not possible. At Valley, we understand the physical, emotional, and psychological challenges of family planning, and we are committed to helping same-sex couples, transgender couples, and single individuals of the LGBTQ+ community achieve their dream of family and help them on their journey to parenthood. Using the latest assisted reproductive technology, we offer a range of treatment options that can help you reach your goal. Thank you for listening, and I'd love to take any questions that anybody may have.
Thank you so much, Dr. Greenseid. If anyone would like to submit any questions, you can do that in the Q&A portal located at the bottom of your Zoom screen. And we'll just give that a minute to come in. Okay. On one of your slides, it said a reproductive or reproductive psychologist. Is that someone in your office, or how do we find a reproductive psychologist?
So we have referrals for reproductive psychologists that are in the area, although many will see patients virtually as well. They're not physically in our office, but they are psychologists who have a strong background in reproductive medicine, as well as third-party reproduction. So they're extremely educated with the guidelines that are set forth by the American Society of Reproductive Medicine. And so we help to coordinate those visits.
Okay. As a transgender male who has been on hormones, how long will I have to be off hormones if I want to get pregnant?
This is an excellent question. So everybody responds slightly differently, but it's typical to take about 3 to 6 months for menses to resume. So I
Okay.
think that's, a potential idea of timing. Everybody responds differently. It could be quicker than that, and that is possible, but that's kind of an idea.
Okay. And kind of related to that, does having a history of being on hormones affect um, one's ability to get pregnant?
Excellent question. So there may be some impact on the ability to get pregnant. The studies have shown that pregnancy is definitely possible after hormone treatment, but there may be slight impacts. I think that the best thing to do is to come in for an evaluation, see how things are looking, but it is absolutely possible to achieve a pregnancy.
Okay. If we're not ready yet, is there something we should be doing to get ready?
I think lifestyle modifications, taking care of yourself, being in good health, really keeping an eye on weight, avoiding smoking, excessive alcohol intake, drug use, avoiding exposures to a variety of toxins, all of these things, and keeping a healthy lifestyle with diet and exercise. I think one other thing that is sometimes useful is to see a fertility specialist ahead of time, even if you're not interested in pursuing it this time, just to get a better understanding of your background. Because we take a very detailed history, we want to get you a healthy pregnancy more than anything else. And so we'll go through your entire history and we can discuss ways of optimizing your health in preparation for a future fertility journey.
Okay. Let's just make sure there aren't any other questions coming in. And I'd like to remind our participants that this will be posted on valleyhealth.com/tune into health. And you can do the drop down screen. It'll be under LGBTQ. Thank you so much, Dr. Greenseid, for the informative presentation this evening.